This week on the BackTable podcast.
She had recurrent abscesses in the groins, unrelated to the graft. By some miracle, she never infected any of the grafts. And she thrombosed. The bypass was acutely ischemic. And I did not want to go into that groin. And I also didn't want to risk graft infection. And so we did it. The other thing I did with that case is I went high on the radial. So another trick is you do increase the risk of a pseudoaneurysm the higher you go. But I did go probably, I don't know, maybe a third way up the arm.
You gained like probably 10 or 15 centimeters.
Yeah.
You probably gained a good
you gain like 5-10 centimeters and that's sometimes just enough to get you where you need to be.
Hello, everyone, and welcome to BackTable, your source for all things endovascular and more. You can find all previous episodes of our podcast on any platform like Spotify or even our website, backtable.com. You can follow us on Twitter, Instagram, or LinkedIn and keep up with the latest updates and give us feedback through comments.
Now, a quick word from our sponsors. How often do you hear about mic drop innovations in radial to peripheral equipment? Here's one. The Sublime radial access platform from Surmodics offers 250 centimeter rapid exchange balloon catheters. That's long enough to reach from the wrist to and through the pedal loop. And their unmatched deliverability ensures they get there. Ready for another mic drop? Sublime guide sheaths are available in lengths up to 150 centimeters in both 6 and 5 French platforms. The Sublime portfolio even includes high-performance support catheters in lengths up to 200 centimeters. Getting the picture? The Sublime radial access platform is engineered to make wrist-to-foot access not only possible, but practical. Don't just think radial to peripheral, think wrist-to-foot with the Sublime radial access platform. Visit sublimeradial.com to learn more. Now, back to the episode.
I'm Sabeen as your host today, and I'm happy to welcome Dr. Rami Tadros, who's a vascular surgeon at Mount Sinai Hospital in New York. Welcome, Rami.
Thank you, Sabeen. Thank you for having me on this podcast.
Absolutely. You know, Rami, I've actually heard a lot of good things about you from one of my colleagues and good friend, Paul O'Connor.
Okay.
I don't know if you remember him, but yeah.
Whatever he told you, I'm sure it's a lie.
I hear, he told me that, yes, you're an expert at complex vascular disease. You know your aortic work a ton, but really your true passion is the gym. And lifting weights. Is that still the case?
It is still the case. It's something I've been passionate about since I was 15 years old, and even I'll be 40 next week, and still going strong. So
that's awesome. Yeah, he was telling me about a video he created of you guys. I think at graduation. So we'll have to post that as well later on, but. I think it's really cool and great, the relationship that you guys have with Interventional at Mount Sinai. I think it's unique and it allows for both trainees in both programs to come out well-rounded and even more skilled. I mean, when we took on Paul, he had so many more skills than I had when I came out of my program. So I attribute that to all the good training you guys did. So thanks for all you guys do.
Yeah, no, it's been great. I mean, the training at Sinai is certainly unique. When I'm down in the radiology suite, I bring on the IR fellows, the vascular fellows, and vascular residents. And it's, I think it's the way to train. You learn so much from other people, from other, specialties. Like I also collaborate with cardiology and structural heart and interventional cardiology. So the 3 interventional specialties all collaborate a lot. You learn a lot from each other, which I think is important.
Exactly. You all learn from each other, and instead of competing with each other, it's just way better going the collaborative route. So let's start off. Today we're going to talk about radial access for peripheral vascular, but before that, I did also want to know a little bit more about you. I mean, how did you get from where you grew up and trained to become the site director of aortic disease and even the associate program director at Sinai?
I grew up in the southwest suburbs of Chicago, and after, finishing college, I actually went out to England to start medical school and spent a couple years there before eventually transferring back stateside. And then I ultimately graduated from Ross University, and during my 4th year of medical school, I was rotating on a vascular surgery service, and that's when the integrated vascular surgery residencies were just starting. And the vascular surgeon I was working with, Anil Hangarani, was like, "Oh, you should think about applying to vascular surgery right out of medical school." And I was like, "Okay, I'll think about it." I was actually applying for general surgery at the time, and I decided like last minute, like October 30th or something, to put my name for the vascular surgery match. And I ended up interviewing at University of Pittsburgh and Mount Sinai Hospital, and ended up at Mount Sinai Hospital. And that's kind of how I became a vascular surgeon. So right out of medical school, I did an integrated vascular surgery residency. And at Mount Sinai, we spent a lot of time down with the interventional radiology group. So about several months a year. From intern year all the way through, I probably spent about a year working with the interventional radiologists during my training. Yeah. So I was part of the first class of integrated vascular residency trainees at Mount Sinai. And when I, chose to do integrated vascular surgery, there was only 6 programs in the country and 8 residency positions. So it was a brand new thing. But it definitely worked out, and I'm happy I did it.
That's awesome. So, what is now your practice now? Is it, what's the breakdown like? I know you're a site director for aortic. Are you mainly doing aortic, or what's your practice like?
It is a mixed bag. I definitely treat a lot of aortic disease. My practice is about roughly 50-50 office, hospital. I still do varicose veins and radiofrequency ablations and sclerotherapies in the office. And then at least one day a week, I'm doing aortic work, whether it's a fenestrated EVAR, branched EVAR, sandwiching and snorkeling, custom-made, BackTable modified, you name it. And then at least one day a week, I'm doing arterial disease, mostly minimally invasive, mostly endovascular. But I still do, 25, 30 bypasses a year. So not an insignificant number, but definitely, probably about 200 to 300, but I'd say 300 lower extremity interventions a year, roughly, something like that.
Yeah.
So
sizable. So variety, right? So aortic, PAD, venous, typical of Mount Sinai, I guess, see everything and do everything. Is there a specific, other than being a gym rat and everything, is there a specific passion you have in vascular disease? Like, you come down, you're like, I love my aortic day, or I love my PAD. Like, what do you have anything?
I really do enjoy the variety. I'm definitely passionate about aortic disease. In the last 4 or 5 years, I've gotten busier doing spine access surgery, which is also another good niche. And, pushing the limit with endovascular revascularizations, lower extremity work. I still enjoy that a lot. So I think maybe it's my ADD, but I like doing a lot of different things, keeps me interested, keeps me motivated.
I totally feel you on that. I feel like me too. I mean, that's part of interventional. I couldn't just focus on one thing. I need the variety to get me through the day. So I totally feel you on that. I'm sure all of us in this field has some sort of ADD, because there's no way I could concentrate on one thing. Okay. Speaking of pushing the limits, we're going to talk about radial access specifically for PAD. We're not going to talk about visceral intervention. We're going to be talking about, everything distal aorta down. And I was actually going to try a different format than our typical podcasts. And I wanted to do kind of a debate, a little bit of a debate, because my practice is a very high volume vascular practice. We do a lot of PAD. And I can count on one hand, how many times I've used radial just for PAD. And so I kind of want I'm going to ask you a bunch of questions, and we'll kind of, I want you to convince me why I should be using more, if that's what you believe. So how often are you using radial access for lower extremity intervention?
I would say a year or two ago, I was pushing it a lot harder, and I was doing a lot more of it, partly because of the novelty of it. And, it was, people were just starting to do it, and it can work. I think there's still a lot of limitations with it. That's part of the issue. So I probably do maybe 1 case a month, 2 cases a month for specific reasons, transradial. So hostile groins, patients have had maybe bilateral femoral endarterectomies and not want to stick the patch. So it's very, very specific, situations I think that really favor transradial. And you can treat from the aortic bifurcation all the way down to the tibials. I think, there's several videos on YouTube of us doing like even down to the ankle, transradial. But we don't have all the same tools and variety of different equipment that we have for like, say, transfemoral,
Sure. Yeah, we're going to get into that, the limitations. That's the big thing, right? But how often are you using in your, one case a month, or even when you're doing more, how often are you just using radial, or you're combining it with a different access, such as radial and pedal, or radial and maybe, you don't want to put a big size access in the groin, but you put like a micropuncture sheath combined with radial. How often are you combining it?
Again, it all really depends. Not often. Most of the time, if I'm going radial, it's something I think I can do primary radial. That said, I have done radial pedal. It becomes it's a long distance to then even snare a wire. You need a 450 length wire to be able to do like a radial to pedal snare and have a external wire. So like using a 260 or even a 300 wire often is not going to make it. So I have done it, but it's not something I do often.
Got it. Yeah, no, that's a very important point, that the wire length is a limitation. I mean, we don't have many wires that are greater than 300. So the biggest question is, and you touched on it already, but let's get a little bit more clarification, is why use radial? What are some case situations, hostile groin, etc.? Let's list out a couple.
So, I think that there's certainly a lot of advantages, right? In terms of bleeding risk, patient comfort, patients can ambulate right away. We typically use a TR band for hemostasis. That comes off after about an hour. So the recovery room time is less. Patients often prefer it, like it. And, there's that safety element in terms of bleeding risk, groin hematoma, retroperitoneal hematoma, pseudoaneurysm. So you have that.
And patient anticoagulation, all that
stuff. Yeah, exactly. So there's that issue, right? So there are advantages there. Specific situations where I've used it, I've had a number of patients that I've done aortal bifemoral bypasses on, and so they end up with like a stenosis at like the femoral anastomosis or something like that, where I don't want to access the opposite groin, go up and over. It's going to be a issue through a bypass graft. So coming in transradial, is very, very helpful.
That's a great situation, actually.
Right.
We don't have that. My patient population, I don't have that many aortal bifems that come through. But I mean, that's an awesome example of why use any other access.
Right. I mean, I've pretty much abandoned brachial access almost completely. I mean, every once in a while, if I'm doing like a complex aneurysm and I'm not using the axillary artery, I might consider doing a brachial access. But even, for, some of these complex aneurysm cases, transradial's helpful too, because you can use it for imaging, even thoracic branch devices now for thoracic aneurysms, using transradial as my main upper extremity access. And so I think with what we have available now with transradial, I think it has largely obviated the need to use the brachial artery, which I think is good too.
Yeah, that's great. I mean, in the past, people would say, obviously I don't have surgical training. They say, oh, brachial access is so easy, cut down and close. But I mean, radial, with the devices we have now, I mean, how can you beat, just a simple radial access with no cutting down?
That's right. Yeah, exactly right. Right now, I think probably one of the bigger limitations is the access size, like the sheath size, right? Because you have
6 French is your biggest, right?
Pretty much. And then I have had situations where I want to put a 7 French stent, and I end up using, a 6-7 slender, but a short destination sheath. And then I just got to start off, just try to, use a stiff wire to get like an Amplatz wire down, and rely on, basically no long sheath and just do it that way. So again, you're working around all these limitations. And I anticipate Terumo will come out with a 6-7 slender destination sheath hopefully soon, but it's not out yet.
Why hasn't that happened yet? I mean, why hasn't a 7-8, I'll do neurointervention as well. And we really, use 8 French access, for a lot of intracranial intervention. And I just don't understand why that access hasn't been created yet. I mean, do you have any insight on that?
I think it's in the works. Why it's not out already, I have no idea. You would think it's a sheath, right? Just be easy enough.
It's just easy enough. It's an extra size. But I've just been surprised. I mean, radial access, these slender or thin-walled sheaths have been out for a while now, and I still have yet to see an 8/7.
Yeah, I'm not sure if it has to do with the integrity of the product, and them worrying about, maybe if you get a sheath fracture or fraying or something like that. So maybe there's some integrity issues when you start doing that. And I'm sure there's science and you have a bunch of engineers that are smarter than me trying to figure that stuff out. So
I know. Other than us, just like, hey, just make a bigger sheath. It's not. Well, I love that example of an aortobifem. I mean, that is a great example. Why would you use any other access? Any other kind of just like slam dunk cases where you would say,
if you have like a mid SFA, even down the Hunter's Canal SFA, especially if it's a stenosis, not a total occlusion, that's pretty much a slam dunk. I mean, pretty much any stenosis from the femoral arteries down, it's pretty easy to treat.
Cool. Stenosis. So would you say occlusions like
can. It just
fempop occlusion? Would you even try it? Would you
can.
Try it radial?
Definitely can. Again, the issue becomes what tools you have and what bailouts you have. So if you're dealing with a total occlusion, you're going to use, a 119 probably destination sheath to get pretty far down and, get that down to the common femoral or in the SFA approximately. And then CSI actually makes something called Viper Cath, which is a 200 length crossing catheter that you can use along with a 450 length glide wire. And I've done it, but again, it's a bit of it becomes a cumbersome, setup, right? Super long wires, super long catheters.
Yeah. You're going to lose a little bit of pushability. You're going to lose, pushability.
You definitely lose pushability.
Compared to something like anagrade, like it's that pressure, you're going to lose.
Yeah. So again, you lose that pushability. You can do it, but, I've also been in a situation where I start something like that radial, you spend an hour trying to cross and then you're like, why don't I just go femoral? And then you go femoral and it takes you like 2 minutes and it's like, you know what I mean? So but again, that's pushing the limit, but also highlighting the need for more transradial tools, right? Because that's part of the issue is that you lose that pushability with the longer systems and with the longer sheath and, as compared to say antegrade or even up and over from the opposite femoral. I mean, you still lose.
Still lose that.
You still lose the pushability, yeah.
But yeah, I mean, just like pushing the limits and everything. I mean, some people will critique and sometimes I'll do something that might be a little out there, but I'm like, the only way to do is to push the limits. And if it doesn't work out, then you kind of learn.
Right. Exactly right.
So I like it how you guys try. I mean, you'll try it with radial, then convert to femoral. How else would you know?
Right. And it hasn't happened often. I mean, part of it is, as I'm sure you are and many interventionalists are, we're stubborn people. And so when you get in there and you're like, I started this radial, I'm going to finish this radial. And you spend,
exactly.
You spend an unnecessary amount of time sometimes doing.
It's so true. You get stuck. You're like, I'm going to do it. I decided this way. And we are innately stubborn people.
That's right.
Who have ADD.
That's right. That's right.
Physicians worldwide rely on peripheral catheters by Reflow Medical, and now Reflow is introducing Cora catheters, a unique line of coronary catheters that are setting a new standard for complex PCI. The CoraFlex, CoraForce, and the CoraCross are all engineered with groundbreaking technology, and each device offers unmatched bilateral torque with the lowest overall profile available. For more information, visit www.reflowmedical.com.
Now, just a technique-wise, I'm going to assume that most listeners here kind of are familiar with radial access technique. One thing I kind of noticed when I've used these peripheral slender sheaths is that you kind of have to waste a sheath. When I get access, I'll use a glide slender. Let's say I'm mainly familiar with Terumo, and I know Merit and other companies have, but I'll usually start with like a glide slender and then get an 035 wire down and then exchange for this longer, destination slender. Is that, how you're doing it? And then essentially you waste this one sheath. Is there any way to kind of make that more efficient?
I don't think so. I mean, you could use, I guess, a micropuncture set.
Micropunch.
And
then just push the wire. But that works too.
You know what I mean? But I think that's the way you got to do it. I think you just use the sheath because you're going to also need a catheter to go down and then position your wire, then get your destination sheath down,
Yeah, I was always thinking like, how can I make it a little bit more efficient? But are you familiar? Are all the sheaths pretty much the same then between? I think Terumo and Merit have the two main. I think Bard has created one too.
I'm mostly familiar with Terumo as you are. So I know Merit has product. I've played around with it, but really haven't used it for an intervention. I like the Terumo system. I think it's a good system.
Yeah. I never understood the sizes though, like 109 and 119. I never understood that why it's
now they have even shorter ones too.
95.
They have 95, 85.
Yeah,
so they have like a bunch of different sizes.
I know. I was trying to figure out what the idea was between the size, but the one issue we kind of talked about sizing and lengths. What devices, stents and stuff, are they available that long?
Yeah,
going to the FemPop?
You have a few options. For FemPop, I'll either use Medtronic. They have the Intrust, which is basically their Evercross stent. It's on a 5 French delivery system. That's 150 length shaft. And then Terumo has their own line of transradial, long shaft. And there are pros and cons to that stent. It's a rapid exchange system, and so you do lose some pushability when you're going down low, especially if you're going across something pretty tight. You got to pre-dilate it, of course, first, because you do lose a lot of pushability with the rapid exchange stent that Terumo has. I really like the Intrust stent. Also, I like that Intrust stent because it's 5 French, so you can actually still image. So you can get the stent down. You can still inject around it, but the limitation there is that it's 150 length, and so if you have a tall patient, it's not going to get you down to the Hunter's Canal.
For reference, let's just so like our listeners would know, because not many people know lengths that long from the radial. Let's say 135, which is a very common length for some systems. How far does that get you from? And just say standard 5'8", 5'6", 5'8" patient.
135 will definitely get you the iliacs. Okay. That would probably get you down to the common femoral, and it'll probably get you to the upper third of the SFA. Maybe. So again, everyone's kind of built differently, and then tortuosity also will impact that. So if you have somebody with long arms, tortuous aortic anatomy, you're going to lose a lot of length. But 135 in general will reliably get you to the common femoral, I think.
Okay.
Yeah.
That's a good sign. Then 150 then probably like reliably mid SFA.
Mid SFA. Reliably mid SFA. In a shorter patient, 5'4", 5'3", probably get you to Hunter's Canal or even the pop.
And then we mentioned you have some 200 centimeter the Terumo does. So what about tibial disease? Are you treating tibial disease?
Yeah, the limitation there is not having stents that can reach to tibial. So Ultraverse makes a 220 shaft tibial balloon that I've actually taken from the wrist down to the ankle, a few times. So that is pretty good. And then atherectomy wise, you have CSI as pretty much your only option, which is a good device in the right patient, but they have the long length that's made for transradial intervention. But if you think it's going to be something you're going to stent, again, going back to like a total occlusion, my preference, my typical practice pattern, if I have a total occlusion of anything, it's bought itself a stent. I may vessel prep with atherectomy and angioplasty, but if they came in with a chronic total occlusion, my preference is to try to stent that. The reocclusion rate's just too high, I think. And so if you got a stenosis, I think it's, again, fair game. You can hit the tibials, transradial, no problem.
Sure. Yeah, no, I agree. I mean, I've seen a lot of recans of occlusions, even like a FemPop, and people try to leave no metal behind, and that just occludes, relatively quickly.
Yeah, then it's sometimes hard to get back in and hard to salvage that.
Then it's harder. Yeah, exactly. You would think it'd be easier because you recanted already, but it's not.
Right.
Now, what are some any examples? We did talk about like perfect examples to do with radial. So again, I think the aortobiofem is great, but the opposite way.
So like,
what about
really heavy patients? So you got dealing with a huge pannus, fungal infections in the groin and things like that. Transradial is a good option. Patients that have had endarterectomies, super common femoral endarterectomies. Sometimes they've had,
and there's stenoses there too.
Sometimes you have stenosis there, or if the disease is distal, so you do a common femoral endarterectomy and a patch, and then there's residual SFA disease. If opposite femoral is okay, you can go with the opposite femoral, but sometimes patients have had this done bilaterally, and that's another really good example where you can use transradial.
What about examples to not do? What about an iliac? What about like a severe external iliac stenosis? Would you attack that?
Yeah,
radial?
I think so. I think an external stenosis, yes. It also depends on how calcified. Again, your options are limited in terms of bailout. So if you have to place a covered stent.
Yeah, exactly. Like mostly you put a 7 French Viabond there. What are you going to do?
Right. So now you're stuck. So now you have to either use the ipsilateral groin or the contralateral groin and do some of that, or brachial access. In a pinch, if the groins were not an option,
you had to,
and you had to get a 7 French something down there, which you could probably do. Let's just hypothetically speaking, say you did perf.
Sure.
Say you did perf that external, and you're doing this transradial, and now your patient,
you could just get parallel brachial access.
That's probably what I would do. I'd actually probably put a balloon, leave the wire across, inflate a balloon, just leave the balloon up across the area of perforation, and then either ipsilateral, parallel brachial access, or contralateral, use the other arm and get brachial access, or if the femorals are an option, you can use the femoral in that situation. But in that kind of situation, if you did perf, the key is just not to panic and just reinflate the balloon. And I actually, one little trick is I actually will push the balloon forward over the wire to image, leaving my balloon on the wire, because a lot of times it's just easier to bring the balloon back and then inflate.
Instead of bringing it all out.
Correct. Yeah.
Instead of pulling it out. That's a great, especially when the more time the balloon is down, that's just bleeding there.
Correct.
That's a great,
so like
that's a great trick.
Yeah, I've done that, and especially in a situation like that. I've done that also when I'm doing like a complex EVAR, and most of them nowadays we do percutaneous. You get a common femoral stenosis from the perclose, and similar idea. You balloon that. Most of the time it's fine, but every once in a while it starts to bleed or something, and then I still have the balloon on the wire and just exchange it back a few centimeters.
You get enough good imaging injecting around the balloon?
Yeah, I think so if you're doing these interventions with a 5-6 slender destination, it's 6 French, and most balloons are going to be 5 French, and so it's generally not an issue now.
Yeah. No, those are great. Well, one kind of twist, something that we've tried on some patients and wanted to get your opinion is primary pedal access. What's your opinion? That's just, we're switching now complete gears.
So
we're using similar systems. Now, have you done that?
So, I don't know, maybe I'm a vascular surgeon. I have not done primary pedal. I've definitely done plenty of Safari cases, femoral pedal, radial pedal.
Yeah.
And I typically
a primary pedal, no other access, just straight up a slender sheath in your AT.
I'm not a fan. I worry that
it's pretty traumatic. Yeah.
I worry that you're going to lose that outflow vessel, and so it depends on. And also, if you're doing it for claudication, it's like if you're potentially losing a tibial for claudication. I like when I do anything pedal after I finish the intervention, whatever I need to do, I always plasty the access site. I always get a wire across it, get a balloon up, and I usually do like a 5-minute inflation, and that's worked for me.
That helps a lot.
That's worked for me. It's worked for hemostasis. Yeah, exactly. So
spasm, anything.
Right. So putting in a 4 French or 4 or 5 slender sheath, some people are even doing like 5-6 slender sheaths in the tibials and everything.
I know.
And then stenting the SFA for a primary SFA lesion. I'm very reluctant to do that.
Yeah. No, there's definitely, you can see on socials, and I've had one or two cases that I've done primary pedal, and one of them didn't turn out so good. But it's interesting. Something like a SFA pop, you would rather probably go radial on that rather than a primary pedal.
Right, and you have the equipment to do it now. I mean, you can use the Terumo SFA stent, and that will get you down to the pop. And so, to go just primary pedal, it doesn't make a lot of sense to me. And if you're doing it for CLI, it makes even less sense, because now you're potentially sacrificing a tibial, or you lose that tibial. It's bad news,
Yeah. I mean, I'm also, my technique is very similar to yours, where I always get my wire across. Once I, balloon the occlusion, and I know I don't need that rail anymore, I'll reverse my wire, and I always just get that outflow as best as I can, because outflow is as important as inflow in these patients. So I mean, what do you know? So you've said that your volume of radial has sort of, you tried it more and now it's kind of decreased, and now but you still have kind of a steady reason, and will continue to do radial for PAD.
Exactly.
Yeah. Any other devices that, like, any other technology that's coming out that'll kind of help with radial?
I think a lot of the companies are exploring transradial products, atherectomy systems. I don't know what's exactly coming down the pipeline, but currently we don't have directional atherectomy systems that we can use transradial. Like, we don't have it. I've done a couple total occlusions, like I had a patient that had fem-pop bypass that totally occluded, and I actually used the 4 French angiojet system to get in there. And I've done a few angiojet cases transradial too. So
that's cool.
Yeah, okay. So I've done that a few times. But again,
why'd you do 4 French? Why'd you do 4 French other than 6 French? So is the shaft shorter?
Yeah, exactly. So
on the 6 French,
I needed the longer length. So I needed the 150 length.
Yeah. And 4 French comes in. Yeah, that's right.
Yeah, and then the 6 French is only 120. It wasn't long enough. So
yeah, but
the 4 French worked okay actually for that. And then
that
was a lady that had a prior. She had a fem pop.
Oh God.
She had recurrent abscesses in the groins, unrelated to the graft. By some miracle, she never infected any of the grafts, and she thrombosed. The bypass was acutely ischemic, and I did not want to go into that groin. And I also didn't want to risk graft infection. And so we did it. The other thing I did with that case is I went high on the radial. So another trick is, you do increase the risk of a pseudoaneurysm the higher you go. But I did go probably, I don't know, maybe the third way up the arm. Just
you gained like probably 10 or 15 centimeters. Yeah. You probably gained a good
you gain like 5-10 centimeters, and that's sometimes just enough to get you where you need to be.
Just to go there. Are you okay in that case? Would you have been okay, like if angiojet didn't work, then lysing through the arm, keeping the catheter?
I haven't done that, and I don't know if I would do that. I think my main concern with that would be possibly a vertebral stroke or something. You never know.
Yeah, I had the same kind of question, and we haven't done it, but I think the patients, they're pretty anticoagulated and systemic lytics are on board, but
I don't know.
The last thing you want is
I don't know if the lytic catheters are long enough, like a drip catheter.
Yeah,
I think they're like 150 maybe.
You're right. 150. I wonder if they're 135 might be the longest that I know of. You're right. I don't know. Yeah, but see, these are the things. These are things you have to, before doing a radial case, you kind of just have to think about, and hopefully in the future we'll just have much more devices and lengths that are available. We'll have 8 French radial sheets. I really want that for any company that's listening. Just please make an 8 French thin-walled sheath. That would help a lot, and because even if you have that, then you can even do, bailout stenting in the iliacs and things like that. So I think that'll increase the utility of radial for PAD.
Yeah, for sure. Yeah, I think the big thing is just, when you're doing these cases, to think through them and think about what your bailout is going to be, should it fail, or should something go wrong. I've had cases transradial where we embolize, and now you got a little something in the tibial. And so I've actually used that Viper cap 200 length, go down, empty 20 cc syringe and suck it out. And then it's a pain in the neck because then you have to rewire it again and do it a few times and try to suck the clot out or whatever embolize distally. And so you, again, back to limitations of the device, of the system. And
how long is the CAT RX?
I don't know. How long is that?
Yeah. It's rapid exchange. So if it's long, at least that could help in a radial case, right? Yeah. No, I mean, I think always knowing your bailouts. I mean, I think as more experience you get as an operator, you think, 3 or 4 steps down the line, like on your case, right? Like if something goes bad, just have your stuff prepared, and that's what makes you a better operator. Well, awesome, Rami. I mean, any kind of words of wisdom, whether it's people who are trying radial or just in general to people out there?
No, I think people should give it a try. Take the time to study it, know what you need, what tools you need. You got to make sure that the palmar arch is okay. Usually, compress the radial with pulse ox and, assess, is there good perfusion to the hand when the radial's occluded? Because with the TR band, it's meant to be patent hemostasis, right? But it doesn't always happen that way. So you do sometimes lose the radial artery and it occludes. So you got to make sure.
It's a great question. Speaking of that, I didn't ask it, but I should have. But a lot of people are moving away from doing the modified barbell, based on some cardiology literature and things like that. Do you do that for all? So, I mean, you just mentioned, do you do it for all your cases?
We do.
I'll be honest, I've been decreasing.
So we do it as part of our protocol at Mount Sinai. So it's just kind of reflexively we do it. I've never seen a D, so for those that don't know the classification systems, A, B, C, and D, A and B, even C is okay. You can proceed, but a D supposed to be flat line. It's supposed to be contraindicated. I've never actually had that happen, so I don't even know what the incidence of a Barbo D is.
For you guys too. I mean, Sinai, you guys do a ton of radial.
Yeah, definitely. And so I don't think I've ever seen it. I don't know. Maybe somebody with like hand trauma or something. It's possible, I guess.
Yeah, something, or maybe some, dialysis patient who doesn't have an ulnar artery. Who knows?
Yeah, exactly.
Yeah.
So we've done ulnar too. We've done ulnar. So
okay, yeah.
So
you've done ulnar access.
So the radial we always talk about transradial, but you want that vessel to be 3 millimeters, 2.5, 3 millimeters at least. And so sometimes you look at, and it's like a 1.5 millimeter, 2 millimeter small radial artery, and you're wondering whether it will accommodate the sheath. You look at the ulnar, and the ulnar is big. That's an option too.
Yeah, you would do that. You would go with ulnar.
Yeah, we've done that. It's not frequent, but as many transradial cases that we do comes up like once every couple months where we're having to do an ulnar.
If you, for the purposes of doing peripheral PAD in radial, and you encounter a radial loop, are you still okay with pushing this like 6 French slender
radial loop
destination? You're okay with that?
Yeah, it's not a problem. I don't think. I think you have to get the loop out. So for those that haven't encountered that, you basically, you get a stiff wire and you kind of put back tension on your wire catheter or, wire and sheath and kind of almost pull out the loop, and then it usually straightens out and then you can proceed. The other thing is vessel prep, right? So we use verapamil along with heparin and nitro, and that preps the vessel, and so that you don't get spasm, or at least minimizes the risk of spasm. And then even if you do get spasm, you can redose. You can give systemic nitro. We've gone out and give local anesthetic along the length of the radial artery. Different things you can do.
You can do a brachial. You can do a nerve block.
Yeah,
I've
avulsed a couple. So I've avulsed a couple. In that situation, I've maintained the wire access, and then I've just embolized proximal and distal. So just keep the wire access, and then just, basically get some coils and just coil proximal, coil distal. And I've had a few pseudoaneurysms too, that we've just injected with thrombin like you would any other pseudoaneurysm.
Probably very easy to see, I bet.
Very easy.
Radial is just...
Yeah. You were saying nerve block, brachial nerve block. I haven't had any experience with that.
Yeah. So there's one, I haven't done it, but basically, you can just see the brachial plexus if you're looking at, and just inject lidocaine right there, and that'll dilate. And then also another one is putting a BP cuff up and put it up for like 5 minutes, induce ischemia in the arm, and then take it down real quick. And basically you have a reactive vasodilation that actually helped me in a case once. And so, yeah, there's many different little ways.
One thing not to do is
pull.
Yeah. Well, you sometimes you have to, but if you're going to do that, don't lose your wire, of course. But don't use a non-hydrophilic sheath. I had to bail somebody out for that exact reason. They used a non-hydrophilic sheath in the radial, and it just fused. And then that one I actually just took to the operating room, and I had to I pulled it out and then just
oh my God.
Had to. I just
you got the worm that time. You got the worm.
Yeah, that case. I just I can't remember. I just had to open up the forearm, find the radial artery. I incised I incised it, pulled the sheath out, and then I patch angioplasty the radial artery. I probably could have just ligated it.
Yeah, no, that's cool. That you can fix those problems. That's where us endovascular only specialties. Yeah. I mean, that's
I've done it. I've done just coil the thing. Like I said, I've also few. And when you're down in the radiology suite and you're there and you're the one that just caused the perforation, you're just like, do I really want to go up to the OR right now and still have full day of cases to do? It's not like that.
Yeah, really. Let me just take care.
So I'll just take care of it now. And then now the one advantage I have is if, say, the arm did become ischemic, I can always do a bypass.
Yeah.
So you can always keep that option open.
Yeah. No, that's great. I mean, I think this discussion was really solid. I mean, I love the case examples we've come up with, and even this is and discussion of what can go wrong is really good to kind of discuss about for radial and how to bail you out. So, Rami, thanks for coming on today.
Thank you.
That was awesome.
Appreciate the invitation. It was definitely a pleasure finally getting to meet you.
Yeah, I'll let Paul know, that we're gonna all go hit the gym together at some point.
That's right.
Thanks for coming on and everything, and we hope to have you on soon again too.
Sounds good, man. Take care. Bye-bye.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabeen Dhand,
Michael Barraza,
Jacob Fleming,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff. Design and digital marketing led by Brian Schmitz.
Article and transcript support by Taylor Robinson
and Delaney Aguilar.
Social media and PR by Ann Dang.
Administrative support provided by Jamila Kennebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.